بسم الله الرحمن الرحيم. برحب بحضراتكم في المراجعة بتاعة الليد اند نيك. وأنا عارف إن الموديول مش لطيف شوية، وإن شاء الله يكون يعني بعد المذاكرة وكده بقى معقول. فهنبتدي على طول. ديت أول حالة. This is the first case of CT of the maxillofacial area before and after contrast. Yes, the parotid hemangioma, the answer is right, and this means that you can see and hear me. Okay, and the answer is parotid hemangioma, the second case, and this is post-contrast CT of the neck in the axial and coronal planes, sagittal plane, sorry. No, this is not lymphoma. Yes, and this is thyroid goiter, and the answer is right. This is the huge thyroid enlargement with heterogeneous density. It extends up, reaching the oropharynx and down into the mediastinum. A classic appearance, not that classic, but it is one of the
recording in progress
of the thyroid goiter. The next case, this is a male, 56 years old, with history of trauma. Yes, and this is vitreous hemorrhage and is not rupture of the globe. The globe is intact, but you can see some hyperdensities inside, and this means that this is vitreous hemorrhage. And the vitreous hemorrhage is not one of the manifestations of globe rupture, but it indicates a serious ocular injury. Then the next case is an axial CT image of the neck at the level of the thyroid cartilage. No, this is not cancer thyroid. Laryngeal carcinoma, and the answer is good. Laryngeal cancer, because this is a supraglottic laryngeal cancer before the level of the vocal cords, and you see a big mass affecting the area of the epiglottis, the pre-epiglottic fat, as well as both epiglottic folds, mainly on the left side. And it is very important to look for the presence of any metastatic nodes in the nearby area, but there is no metastatic nodes, and this is a supraglottic laryngeal carcinoma. This is a CT scan of the maxillofacial area showing this lesion, which is centered to the zygomatic bone. Okay, and someone said that this is metastatic deposit, and another possibility is carcinoma. Well, if you see a case like this, and the first step is to ask yourself, is this a benign lesion or a malignant lesion? And of course, you can easily answer this question because the lesion is centered to the zygomatic bone, which is almost totally destroyed, as well as the zygomatic arch. with, let us say, invasion of the fat in the infratemporal fossa. Then we are dealing with a malignant lesion. And the malignant lesions, as you know, are three. Number one, the carcinoma of this place. Number two, lymphoma. Number three, metastatic deposit. And whenever you are asked to select one of these, then you have to select the most common, which is the carcinoma. And if you know that this patient had a primary malignancy like papillary thyroid cancer, then you know that you are dealing with a metastatic deposit in the zygomatic bone. And you are not allowed to diagnose metastasis without a clear history of a known primary malignancy. Next case. Schwannoma on Castleman disease, nasopharyngeal carcinoma. Okay, and this lesion is not in the nasopharynx and is not also in the oropharynx, because you can see that the fat is displaced anteriorly. Then the parapharyngeal fat is displaced anteriorly. Then you are in the region posterior to the parapharyngeal fat. In this area, you have three lesions: the glomus tumors, the schwannomas, and the lymphadenopathy, whatever the etiology of these lymphadenopathy. And the glomus tumor should enhance markedly, and this is not marked enhancement. The lymph nodes should be multiple, and you should not see a single lymph node which is very big like this, and you cannot see any other lymph nodes in the scanned area. Then you are left with schwannoma, and the answer is schwannoma in the carotid space. Next case is a CT of the parotid glands. You can see bilateral parotid lesions. Yes, pleomorphic adenoma is not multiple in the same gland. And here you can see two lesions in the right gland and the big one on the left gland. This is Wharton tumor, and the answer is more or less near to the right answer. But you should remember that for diagnosis of Wharton tumor, you should know the age of the patient. It should be an elderly patient and with positive history of smoking. This is good for Wharton tumors, and this is also good for lymphoma, as you know that there are intraparotid lymph nodes which can give rise to lymphoma, as in this case. Next case is an axial and sagittal reformatted images of the neck, where you got a heterogeneously enhanced mass on the right side. And these are the suggested diagnoses: TB lymph nodes, metastatic nodes, vascular malformation, and submandibular carcinoma. And yes, someone said that this is carcinoma, and the submandibular carcinoma. And actually, if you look carefully, you can see that the submandibular gland is a little bit seen through the lesion. And you know that one of the groups of lymph nodes in the neck are those which are located in the region of the submandibular salivary gland. And if you look to the sagittal image, and you can see the characteristic appearance of the nodes with central areas of breakdown. And if you know from the history that the patient had a positive history of melanoma, then you know that these are metastatic lymph nodes. We can see that the nodes are adherent to each other. They invaded the skin and the subcutaneous fat. Next case is a patient with a cystic mass in the neck, and this is the CT with contrast, and this is MRI with T2 weighted images. The provided possibilities, as you can see, are an abscess or branchial cleft cyst or lymphangioma or hemangioma. Yes, the answer is right, and this is lymphangioma because of the fluid levels inside the lesion, best appreciated in the MRI. This is the right answer. This is lymphangioma of the neck. And this is a spot diagnosis case of a lesion in the orbit, which is a meningioma of the optic nerve, and this is right. The meningioma is seen surrounding the optic nerve, which appears as a radiolucent or hypodense tract within the homogeneously enhanced tumor tissue. This is a classic appearance of optic nerve meningioma. The next case is a CT of the neck at the level of the parotid glands, and what do you think? Parotid abscess and stone, parotid abscess, stone, parotid gland enlargement. Okay, the answers are good. And if you look carefully, and you can see this radio big calculus at the end of the parotid gland duct, and the duct is markedly dilated. It is obstructed by the calculus, and the duct is markedly dilated with the stasis of the secretions and the enlargement of the parotid gland with the stranding of the subcutaneous fat, meaning that this is an obstructed parotid duct with the formation of an abscess along the dilated duct secondary to the calcular obstruction. And this is also a case that is easy in the diagnosis. And this is, of course, a branchial cleft cyst, second arch. Typical location, posterior to the submandibular salivary gland, anterior to the sternomastoid muscle, and lateral to the carotid vessels. This is a branchial cleft cyst, second arch. The next case is a male child, 4 years old, with excessive rhinorrhea, and you can see in the MRI T1 big mass in the nose as well as in the infratemporal fossa. The mass is heterogeneously enhanced, and you can see the full extent of the lesion inside the nose, inside the orbit, as well as in the infratemporal fossa. These are the diagnostic possibilities: nasopharyngeal angiofibroma, lymphoma, rhabdomyosarcoma, or inverted papilloma. The answers included angiofibroma, inverted papilloma, and rhabdomyosarcoma. The answer is rhabdomyosarcoma because this is not an angiofibroma, is not typical appearance and not a typical age, and not a typical extension of the tumor and even the vascularity. But you know that rhabdomyosarcoma is one of the pediatric tumors that 70% of the tumor occur before the age of 12 years, and it is an invasive tumor with heterogeneous enhancement. Then this is a mandibular panorama showing a typical lesion in the mandible. Yes, and this is keratocyst. Good answer. The keratocyst is the only one which can be multiple or can be a huge lesion that can affect the whole mandible from left to right. The keratocyst is a relatively common lesion when compared to the ameloblastoma, which is the most common after the odontoma. Then the age of incidence is between 10 and 20 years. The lesion is characteristically multiple, and if there is multiple lesions, there are multiple lesions, it is easy for the diagnosis. And it is unilocular compared to ameloblastoma, which is multilocular, and this is a benign non-aggressive lesion, while ameloblastoma is a locally aggressive tumor. Next case is a series of post-contrast CT scan of the orbits. Yes, the answer is right. This is an orbital pseudotumor. The classic appearances are present on the left side. There is reticulations of the intraorbital fat. There is a swelling of the lacrimal gland, and you got some thickening of the posterior sclera and some prominence of the extraocular muscles. Next case is an MRI of the upper neck in the T1, T2, and the post-contrast T1 weighted images. Hemangioma, this is not the signal of hemangioma in the T2. In the T2, hemangioma is very bright actually. And in fibrous dysplasias, there is no bone here, and this is the cervical spine, and this is just the yes, and this is the plexiform neurofibroma, and it's a good answer. You see that the lesion is of multiple small lesions. Some of them may show the classic appearance of a target sign, but considering the huge size and the filtrative character of the lesion, this is plexiform neurofibroma. And this patient had a very, or let's say, slowly growing neck mass. Hemangioma of which thyroid carcinoma. Hemangioma, no, this is not the pattern of enhancement nor the calcification. This is a big mass in the left thyroid lobe, and it shows dense calcific foci as well as central areas of breakdown. And you should suspect in such cases, especially whenever the lesion is unilateral and is big, you suspect a thyroid cancer. And you cannot actually know which of the four types of thyroid carcinoma this mass. But we just say this is thyroid cancer, and it's easy to get a needle biopsy from the lesion to know the histologic type. And this is an MRI of the cella with coronal and sagittal T1 post contrast. It is not just a macroadenoma, but it is an invasive pituitary adenoma, because you see that the lesion is huge in the supratentorial area. But what's very important is the invasion of the skull base and the extension into the sphenoid sinus and even into the nasopharynx. At that time, you should say that this is an invasive type of pituitary adenoma. But if there is no infracellular extension and there is a very big supracellular extension, this is just an adenoma. Invasiveness is judged by the presence of infracellular extension destroying the skull base. And this is a CT of the nasopharynx showing in a male patient, 53 years old. Yes, and this is a straightforward case of nasopharyngeal carcinoma. It is medial to the parapharyngeal fat, and is obliterating the fossa rossi molar and the Eustachian tube. And this is a classic nasopharyngeal carcinoma. CT of the neck at the level of the hyoid bone with intravenous contrast. Yes, and this is thyroglossal duct cyst with carcinoma inside. Very good, good answer. This is a thyroglossal duct cyst, midline cyst in the neck, is diagnostic of thyroglossal duct cyst. And if you see a mass inside the cyst, that can show, sometimes it can show calcium and can show enhancement, then you think of a carcinoma developing inside the thyroglossal duct cyst. And the type of carcinoma usually is the papillary type. And this is MRI T1 and coronal T2 weighted images of the neck of a female 55 years old. Yeah, yes, very good. The answer of lymphoma is good, but this is, of course, is not a glomus tumor. There is no an composed contrast images here. All what you can see is that there is a big mass in the region of the tonsil on the left side, and you may appreciate another mass on the right side. And what is very important is a bulky lymph node on the left and another lymph nodes on the right side, and in the presence of a homogeneous mass and homogeneous lymph nodes, and the lymph nodes are bulky, you may think that you are dealing with a case of lymphoma. And this is a male, 36 years old, with HIV positive, presented by dysphagia and left cervical mass that had grown within about 8 weeks. The tumor borders could not be clearly defined on ultrasound. Yes, very good, this answer. Anaplastic thyroid cancer. And this type is very rare. It's an anaplastic type of thyroid carcinoma, but sometimes you can spot this from the films based on the tumor is big and there is a good part of the tumor that is necrotic. And based on these findings, you may diagnose the possibility of anaplastic type of thyroid carcinoma. And this is a CT of the vitreous bone. Yes, very good. This is a superior semicircular canal dehiscent syndrome. You see that the bony margin covering the superior semicircular canal is not present. This is the lateral semicircular canal, and this is the facial nerve, of course. The arrow points to the facial nerve, which is crossing below the lateral semicircular canal. And you know that sometimes the bony covering of the superior semicircular canal is deficient and the canal is dehiscent, as you can see in this diagram and this CT scan. And the arrow points to the deficiency of the bony ridge covering the superior semicircular canal, diagnostic of superior semicircular canal dehiscent syndrome. The next case is a CT and MRI of the neck, and there are two lesions best appreciated in the MR images. Yes, both are hemangiomas, very good, because of the presence of calcified Philippoli in both lesions, and also the very bright signal in the T2 weighted image. These are hemangiomas. CT of the neck at the level of the submandibular salivary gland. Very good, and both answers are good. This may be a pleomorphic adenoma and maybe a carcinoma. You cannot separate both unless you can see evidence of malignancy, like the presence of invasive character of the adjacent soft tissues or the presence of metastatic lymphadenopathy. Then this lesion was proved by biopsy to be a pleomorphic adenoma in the submandibular salivary gland, which is a little bit rare compared to the pleomorphic adenoma of the parotid gland. But on CT scan, we cannot differentiate between benign and malignant lesions in the submandibular gland. By MRI, we can sometimes differentiate both based on the T2 weighted image. If the lesion is bright in the T2 weighted image, meaning that the water content is high and it is more or less benign. But if the lesion is of intermediate signal or a little bit dark on T2 weighted images, then you assume the possibility of a malignant lesion with many exceptions for this rule. Next case is a selected image from the paranasal sinuses MRI T2 axial image. Fungal infection and inverted papilloma. Good answers. Actually, this is the fungus in the sphenoid sinus, and this is the inverted papilloma. You see that the mass is predominantly located in the nasal fossa and has extended inside the antrum, which is not expanding. And this can differentiate the inverted papilloma from the antrochoanal polyp. And you may see what is known as the cerebriform pattern of the lesion, which is not a constant finding, but whenever you see that the nasal fossa is expanded and the sinus is not enlarged, and you think of this. Next case is CT scan of the neck at the level of the submandibular salivary glands. Yes, aggressive mass. Okay, and then I have mentioned before that if you are confronted by a lesion like this, then you have to ask yourself first, is this lesion a benign lesion or a malignant lesion? And if you decided that this is a malignant lesion, there are only three possibilities: the carcinoma of this place, the lymphoma, and the metastatic deposits. And actually, metastases are diagnosed by a known history of malignancy. And the two possibilities of carcinoma and lymphoma, you should select carcinoma because carcinoma is much more common than the lymphoma in the head and the neck, of course. And this was a squamous cell carcinoma in this particular place. Then many of you may ask, how can I judge that this is a malignant lesion? It's well defined and let us say clearly separable from the adjacent parts like the submandibular salivary gland and the carotid vessels and the sternomastoid muscle. And there is a way of thinking that sometimes I follow whenever I cannot decide or separate between benign and the malignant. Then I ask myself, if this is a benign lesion, what is the diagnostic possibilities? And if I failed to find an answer, then the opposite is the right one. And if I asked you what the kind of a benign lesion located in this area, this is the site of lymph nodes in the neck. And if this is a lymph node, it should be malignant, of course. Then we have to think that this is a malignant lesion based on the discussion I have said, and you cannot find a good answer for a benign lesion in this particular area. Next case is an easy one. This is a post-contrast T1 fat set for the mouse floor, and this is a T2 weighted images, and the answer is easy. This is a spot diagnosis case of dermoid cyst in the floor of the mouse with the characteristic sack of marble sign, as you of course have heard in the lectures. The next case is a series of images that are obtained after intravenous contrast injection, including the floor of the mouse, and the orbits in the axial and the coronal planes. No, and this is not a schwannoma. The calcified philipuli are very characteristic in this particular, and the answer of hemangioma is good. And this type of hemangioma is known as the capillary type of hemangioma, which is creeping inside the orbit, inside the infratemporal fossa, and the presence of calcified fibrillary is a good diagnostic landmark for this type of capillary hemangioma. Of course, you know that cavernous hemangioma is a localized intraorbital, well-defined, homogeneously enhanced lesion that may contain also fibrilla. The next case is an axial T2, T1, and T1 post contrast for the orbit. No, this is not persistent hyperplastic primary vitreous because the globe is not bright in all bulk sequences. There is a mass inside the globe, and in such a case, you should know the age of the patient because this will decide if it is retinoblastoma or a melanoma. And if you know that this is a pediatric patient, then you know that this is a retinoblastoma. And I'm sorry that I didn't include the age of the patient in this case, but this is a retinoblastoma. You know that MRI is deficient in detection of calcium in retinoblastoma, but you depend on the age of the patient. If this is a pediatric patient and there is a mass inside the globe, you think, of course, of retinoblastoma. Male patient, 38 years old, with swelling on both sides of the neck for 2 years. And this is glomus, but the glomus vagal should displace the carotid arteries anteriorly. The glomus vagal occurs posterior to the carotid, but the carotid body tumor occurs at the bifurcation of the carotid arteries. And if the lesion is big, it will encase the arteries, but the glomus vagal will displace the carotid vessels anteriorly and the internal jugular vein posteriorly. Then this is a case of bilateral carotid body tumor is marked enhancement of the lesions. This is the child, 3 years old, with strabismus, and this is MRI of the brain, including also the vitreous bone. Yes, the answer is good. This is vitreous epicitis or apical vitrositis, and this is a complication of otitis media. The patient had otitis media. And you see fluid signal in the mastoid ear cells as well as in the middle ear cleft, and you got bone marrow edema at the apex of the vitreous bone, and it is enhancing after contrast injection in spite of the literature that says that apical vitrositis do not enhance, but many of the cases that I have seen in the clinical practice show evidence of contrast enhancement, and also it shows evidence of diffusion restriction, and this is not a cholesteatoma, but this is an apical vitrositis secondary to automastoiditis on the same side. The next case is a male patient, 50 years old, with rhinorrhea and episodes of epistaxis. Yes, right. This is olfactory neuroblastoma or neuroblastoma. Typical location, typical appearance, typical extension in the floor of the anterior cranial fossa. And actually, if you see this lesion, you may have four diagnostic possibilities. And the first one is the carcinoma of this particular area, which is carcinoma of the ethmoids. The second one is lymphoma. The third one is metastasis. And this particular place, there is a fourth diagnostic possibility, which is olfactory neuroblastoma. Olfactory neuroblastoma is a slowly growing tumor arising from the olfactory epithelium in the nasal cavity, and it has a peak in the second decade, and another peak in the fifth or the sixth decade. The presentation is by rhinorrhea or epistaxis, and the lesion have a destructive attitude and they extend intracranially many times, and it shows marked enhancement on the CT and MRI, and is treated by surgery, chemotherapy, as well as radiotherapy. And the prognosis is affected if the lesion gives metastatic deposits. The next case is a male teenager, 17 years old, and this is a CT of the orbit. No, this is not a coloboma and not a staphyloma. Yes, and this is not the right answer. It's right, the hypoplasia. This is deficiency of the greater wing of the sphenoid bone, which is a classic finding of neurofibromatosis type 1, and the rest of the changes are also the sequelae of neurofibromatosis type 1 compared to the normal sphenoid, greater sphenoid wing on the right side. Here there are deficiency, and you see the changes in the temporal lobe. Next case. This patient is 70 years old with bilateral painless neck swellings. Yes, Wharton tumor is a good answer, and also one of the answers that appear good to me is bilateral pleomorphic adenoma of the parotid glands. It can occur at any age, and they are usually well-defined, homogeneously enhanced, and may occur bilaterally, and can also be of variable size. This is a CT scan of the vitreous bone, axial bone window, axial non-contrast, axial post-contrast, and the coronal bone window. Yes, and this is glomus jugular, very good. A glomus tumor that is centered to the jugular fossa with destructive changes. And whenever this tumor is or has extended inside the middle ear cavity, then you call it glomus jugulotympanicum. But if it is confined to the jugular fossa without extension into the middle ear, this is a glomus jugular. Next case is an MRI T1 and T2 weighted image just of a parotid lesion on the left side. Branchial cleft cyst is not totally present inside the parotid gland. Part of the cyst is present inside the parotid gland, and the other part is related to the pharynx. But this is a classic appearance of a pleomorphic adenoma. They see the brightness in the T2 weighted image, which indicates a lot of water inside the lesion, diagnostic of benign etiology. And this is a case of a tumor in this is sagittal T1, and this is axial T2, and this is sagittal post contrast. Yes, the answer is right, and this is chordoma of the clivus. You see the very bright signal in the T2 weighted image and the enhancement after contrast and the destruction of part of the clivus. All these are in the classic midline location of the tumor are helpful in reaching the diagnosis. Okay, and then this is CT scan of the paranasal sinuses showing mass in this area, and it has extended also inside the orbital cavity and the ethmoidal air cells. No, this is not, of course, the inverted papilloma. This is carcinoma, like classic appearance of carcinoma in the, let us say, it started in the ethmoids and has invaded the maxillary sinus and as well as the nose and extending into the orbital cavity. The first tumor, malignant tumor you think in the maxillofacial area is carcinoma, which is very common compared to other possibilities. And this is a classic appearance of carcinoma in the ethmoids. The next case is a post-contrast scan at the mouth floor and the level of the oropharynx. Submandibular tumor, we do not have the level of the submandibular, and this is tongue cancers. This right, there is an enhancing lesion at the tongue proper, and it is on the left side. It has not extended across the midline. There is no associated metastatic lymph nodes in the scanned area, and this is tongue carcinoma, the classic appearance. Next case is an MRI of the vitreous bone, and this is coronal T2, and this is coronal T1 post contrast. Okay, and I think that this is a difficult case, but let's look at the post-contrast scans, and you can see enhancement in the region of the cochlea and the labyrinth, and this enhancement no, this is not acoustic neuroma. The enhancement of the fluid in the labyrinth. If you go back to the T2 weighted image, you can see that the fluid in the cochlea is not that clear compared to the opposite one, and this is diagnostic of labyrinthitis, acute labyrinthitis. In acute labyrinthitis, actually, in the T1 weighted image and in the T2 weighted image, you see nothing. But if you inject contrast material and you see some enhancement in the labyrinth, whatever is in the vestibule or in the semicircular canals or in the cochlea, then you know that you are dealing with labyrinthitis. This is a male patient, 17 years old, with a lot of homogeneously enhancing lymph nodes in the neck. And these are the possibilities: lymphoma, Castleman disease, mononucleosis, hyperplastic lymph nodes. Lymphoma, Uh, yes, one of the possibilities, of course, that infectious mononucleosis is the right answer. And actually, in cases of infectious mononucleosis and Castleman disease, you got a significant contrast enhancement of homogeneously enhanced lymph nodes. Lymphoma it does not enhance like this. And you can also see the enhancement pattern of the tonsils, which is one of the common sites to be affected by the infectious mononucleosis. This patient, the CT of the orbit, axial, and coronal planes, and you can see that there are some masses inside the orbits on both sides. And this is lymphoma. Okay, then this is a good possibility because multiple enhancing masses in a single orbit or in both orbits are usually pointing to the diagnosis of lymphoma. But if you see a solitary mass that is homogeneously enhancing in one orbit, then you know that the most common answer is the cavernous hemangioma. This patient is an infant, 4 months old, and here you can see a series or selected images from post-contrast MRI scans as well as an image of diffusion restriction, diffusion weighted image. Okay, I think that you got tired. In this infant, you can see, yes, this is a trilateral retinoblastoma. In this age, you see masses in both globes and diagnostic of bilateral retinoblastoma. And you see a mass also in the suprasellar area, and the diagnosis is trilateral retinoblastoma. And you know also there is a collection of lesions that are known as quadrilateral retinoblastoma. Whenever you can see, where you can see two masses in the globe, mass in the suprasellar and mass in the pineal body region, this is quadrilateral retinoblastoma. Male, 33 years old, with two history of mainly swelling in the midline of the neck. Ectopic thyroid. Actually, this is let us say it's not the right answer because you know that the thyroid, whenever it is ectopic, the most common location of the thyroid is at the base of the tongue or in the floor of the mouth. But my advice to you, if you see a mass like this, if this lesion is cystic, then you diagnose this is the thyroglossal duct cyst. And if a tumor arises inside the thyroglossal duct cyst, it will be a carcinoma inside the thyroglossal duct cyst. But if the mass has totally occupied the whole cavity of the cyst, then you think of a thyroid cancer within a thyroglossal duct cyst that has been totally obliterated by the thyroid mass because the ectopic location of the thyroid at this level is not actually known in the clinical practice. Then this is a CT scan of the orbits. Yes, orbital cellulitis, right answer, because you got ethmoidal sinusitis and the inflammatory changes in the left orbit with, let us say, subperiosteal abscess, edema of the periorbital soft tissues, as well as some proptosis. All these point to ethmoidal sinusitis and orbital cellulitis. And this is a selected image from CT of the petrous bones. Yes, and this is cholesteatoma because you got a well-defined mass that is non-dependent and is present between the ossicles and the inner wall of the middle ear cavity. And you know that this is not the Broca's space. The Broca's space is here, and this space has no particular name. But if you see a lesion that is localized and not dependent, you know that this is cholesteatoma. CT and MRI of the vitreous bones. Yes, diagnosis is right. This is an endolymphatic duct and a sac, or what is known vestibular aqueduct syndrome. The vestibular aqueduct is very wide on both sides, and also you can see in this MRI that the sac is very dilated bilaterally, diagnostic of bilateral vestibular aqueduct syndrome. هذا وبالله التوفيق.